Hi, this is Dr. Keynes. I want to review the risks of robotic prostatectomy in detail. Sometimes it's important not to completely reinvent the wheel. My colleague, Dr. Sanchez Ortiz, has a video which I think is fantastic. And so I'm going to have you watch his video on the risks. It's kind of long, it's about 21 minutes, but well worth your time. And if you have any questions, please ask me personally. Thanks for taking the time.
Good morning. My name is Ricardo Sanchez. I'm a urologic oncologist with a focus on prostate cancer, practicing in San Juan, Puerto Rico. And I wanted to talk to you a little bit about the robotic prostatectomy. Particularly, I wanted to discuss the risks of the operation. Now, I wanted to preface this talk by saying that this is not an experimental operation. It's a newer operation, but I learned how to do it 20 years ago and have been doing it here in Puerto Rico for 15 years with over 2,000 patients. And so it's an operation we feel very comfortable with. And thankfully, it's an operation that rarely has major complications. Now, there are some more common complications or side effects of the operation, and there is a difference between one and the other because there are some things that we expect that will happen and will slowly get better over time. So I do not want this talk to be a gloom and doom talk. Because thankfully, most of the things that I will be talking about are very rare that they would happen, and many have never happened to me as a surgeon, but it's important that you recognize that they can happen, okay? And I will be talking about the general risks of any operation as opposed to the specific risks of the radical prostatectomy. So these are two different things, okay? The consent that you will be signing will say robotic radical prostatectomy, possible pelvic lymph node dissection, possible hernia repair, and possible open surgery. And I'll explain what that means. Basically, prostate, here's a model. The prostate is right here underneath the bladder. Okay, so we will remove the prostate with some glands that are behind the prostate called the seminal vesicles, okay? The pelvic lymph nodes are present outside the prostate near the artery that goes to the legs and the veins that bring blood back from the legs. This white structure here is what we call the ureter, which is coming down into the bladder, bringing urine from the kidney. So most patients will need to have their prostate removed, and some patients, maybe half or a little more, will need to have their lymph nodes removed, depending on what type of cancer that they have. We usually use a calculator based on the number of biopsies they have, the type of cancer, to decide if the lymph nodes need to be removed or not. The reason for removal is that when the cancer leaves the prostate, it does it with two strategies. Either it burrows like a root outside of the prostate locally near the prostate, or it sends cells like a bee that leaves a beehive and usually ends up in the lymph nodes as the first landing site. So that's why we remove them. If the risk is low, if it's less than 5%, we usually do not do a node dissection because it takes more time and it may be associated with greater risks, as I will discuss. So when you the first thing that I wanted to let you know is that we will ask you to drink clear liquids the day before surgery. The day of surgery, you'll be fasting, so you cannot eat anything after midnight. The morning of surgery, when you wake up, you need to administer yourself a fleet enema. If you don't have any kidney problems, if you do, please let us know, and you should not use fleet enemas. So your colon is clean when you come in, and we'll put some IVs in you. You'll talk to the anesthesia team, and they'll take you through how the anesthesia works. It will be general anesthesia, so you'll be asleep for about 2 or 3 hours. The typical operation takes 2 hours. If you need your lymph nodes removed, it may take 2 to 3 hours, so a little longer. We have found that patients who have a large prostate or have had difficulty voiding over the years may have a higher risk of finding a hernia. A hernia is basically an opening communication between the abdomen and the testicles, okay? Some patients may have a hernia and not know it because it's plugged with fat. And then when we bring down the bladder to get to the prostate, it becomes exposed and suddenly you see the opening. And we don't like to leave it open because you can have bowel or intestine sneak in there and then cause problems. So it's not a big deal. It's very easy to fix. We usually either put stitches if it's a small one, or if it's a larger one, we'll put a patch with mesh. It's very rare to have a complication of having chronic pain or have an infection of the mesh. I have never had a patient have that problem because we're very careful with making sure that there's no active infection when you go to the operating room. But it is a risk, both of those things. Never had a patient with erosion of intestine or bladder into the mesh, but it can happen. Now, the reason why the consent says possible open surgery is that we do the operation robotically, but there may be a reason for a patient to need to have it done open. Now, that is very rare. Haven't had to do it in over a decade, but it's always a risk, so it's on the consent. Okay. When you arrive, we will give you some pain medication even before you go into the operating room. We'll give you some Tylenol. We'll give you some Neurontin, which is also helps prevent pain. So even before we make the first incision, you will be taking pain medication. Then we will you'll go to sleep, and we'll put some pillows all over you to make sure you're comfy, and there are no pressure points that may cause some nerve problems after the operation. We'll clean up and sterilize the abdomen and genital area. We'll put a catheter in your bladder, and then we'll also do a block with anesthesia before we make the incision. So that really helps. We have found that reduces the risk of pain after the operation as well. By the end of the operation, you will have 6 keyhole incisions, 1 in the belly button and 2 on the right side and 3 on the left side that are about the size of a keyhole. And then you have a larger one that's about 2 inches that's right near the bikini line. That's where we take out the prostate. Okay. Those will be closed with absorbable suture, so those dissolve. You don't need to come back to have those removed. And the skin itself will be closed with a special glue, like crazy glue, if you will. And that works really well. So when you wake up from the surgery, you may feel like you need to urinate because of the stitches that we use to connect the bladder to the urethra. That usually goes away by the afternoon. By the afternoon, you'll be up and walking around upstairs in your room. It's a private room, so your family can stay with you if they want. So thankfully, having severe pain with the operation is not a big issue. Now, most of these risks that I will tell you, thankfully, are very, very rare. So I don't want you to be scared. I just want you to know. Okay. So there's always, with any operation, there's always a risk of an anesthesia complication or an allergy to medications. There's always the risk of pneumonia, heart attack, or stroke, or hernia from the incision, from pulmonary problems, but thankfully that is very rare. Specifically related to this operation, probably the two things that worry patients the most are control of the urine and erectile problems. So you will have to wear a catheter for about a week. Sometimes you need to have it later. It's very rare for someone to have a leak from the anastomosis. They may need to have the catheter a longer time or have a drain placed if there is some leakage of lymphatic fluid or urine outside the bladder. When I say rare, it's about 1 to 2%. Okay. So usually you leave the catheter. Let's say you have your surgery on Monday. You'll leave on Tuesday, and you'll come back the following Tuesday to the office. We'll take the catheter out. 99% of patients go home without a catheter. Sometimes they need to have the catheter replaced, but that's very rare. Okay. We'll give you some instructions about how to help with your urinary continence. Usually, patients will have to use diapers for about 2 to 3 months after surgery. We do have maybe a quarter of patients who never have incontinence, especially those who are athletic or young or very thin. But that is more the exception than the rule. So we'll teach you what are called Kegel exercises. So these are exercises to help strengthen the pelvic floor, and it's important for you to try them before surgery. And basically, when you're going to the bathroom, try to stop your stream and start it again. Stop it and start it. When you stop your stream, those muscles that you contract, those are the ones that we want to strengthen after the operation. And you can practice before to try to make sure you know how to do the Kegel exercises. Now, with regards to erectile function, when we remove the prostate, we need to separate the nerves that are on each side of the prostate that go to the penis. That brings electricity to the penis, so the penis can open up and fill up with blood. Now, that is somewhat of an exaggeration. An oversimplification, because those nerves actually crisscross through the prostate as well. So we are removing them, and the erection will always take time to come back because your body needs to get used to the new wiring, if you will. Okay. So that's why we recommend taking pills like Cialis or Tadalafil or Sildenafil, which is Viagra, and using the vacuum device, which is this here, which is a mechanical way of improving erections. And there's a short video that will explain how these are used. You can find it on our site too. So typically, it depends on your age, if you have comorbidities like diabetes, high blood pressure, how quickly your erections will come back. But in my experience, usually about 2 to 3 months, you start having spontaneous erections, and then it may take up to 1.5 years to, as you continue to take these pills and then slowly wean off these pills. There are patients who need to have part of the nerves removed or the entire nerve removed, depending on how much cancer you have. There are patients who have pre-existing problems with erections before surgery. So those patients will have a higher risk of having problems after the operation. Now, when we do the operation, we're very careful with all the structures around the ureters, which come down from the kidney. Can get injured. It's never happened to me, but it can happen. Sometimes the ureters, some patients may have more than one ureter on each side, or they can have them insert into the wrong place. Instead of into the bladder, they can go into the seminal vesicle. I have seen that and have had to do a re-implant, so plug the ureter back into the bladder because it was inserting into the wrong place. But that is super rare. In over 2,000 cases, I've only had to do it once. and we don't call it a complication. It's more of a curiosity because it's a congenital anomaly that the patient has. In terms of the rectum is very close to the prostate in the back. I'll show you on the model. Right here, if you see the prostate is here, the rectum is here. So you can see how close it is. So usually there's a nice layer of fat, which is yellow here. That nice layer of fat helps us, separate the prostate. But some patients, if they've had many infections, if they've taken hormone therapy, if they have had radiation, or they have a lot of cancer, it may be very stuck to the rectum, so it's difficult to separate. Okay, I've never seen it happen with a robotic prostatectomy, but you can have injury to the rectum, and if it happens, we know how to fix it. It's very rare that you would need a colostomy. The risk is 1 in about 2,000. And the risk of a rectal injury, I would say it's about 1 in 300. So it's very, very rare. But if it happens, we're prepared to fix it. And if it's promptly recognized in the operation. When we do the operation, we are very careful when we sew the bladder to the urethra to make sure that it's nice and tight. It's literally like a baseball stitch all around, to prevent any stricture, any narrowing of the urethra in that area. With a robotic prostatectomy, it's actually relatively uncommon as opposed with the open surgery. But occasionally we do see patients that may get narrowing of the urethra at the tip of the penis. So if you see after the operation, maybe 6 weeks afterwards, that you're avoiding very well and suddenly your stream is spraying or it's very thin, you need to let us know. But the risk of that, again, is less than 3%. So it's not very common at all. In terms of positioning, when we put you in position, you will have your head down and your legs up, okay? Because that helps us get bowel out of the way. You need to let us know if you have ever suffered from glaucoma, which means it's a condition of the eye where you have high blood pressure. We will send you to the ophthalmologist before to make sure that your blood pressure is well controlled, and we'll give you your drops that morning. I've never had a problem with a patient having visual loss after the operation, but it has been reported. We're also very careful to put some lubricants in your eye and close your eyes with tape, just to make sure that you don't get your eyes dry up during the operation, that you may have some problems with the outside of the eye, which is called the cornea. That can happen, but it's, again, very, very rare, and we're very careful with that. When you get positioned, we make sure that you have pillows all over, behind your knees, in your sides, to prevent any nerve injury, either to your legs or to your arms. That's called Neuropraxia, which is basically a problem with the functioning of the nerve. So you can have some numbness or pain in the leg or the arm, or weakness after the surgery. I've never had a patient have that permanently, but occasionally patients may have it temporarily, and we will recommend some exercises for that if it does happen. To prevent blood clots in the legs, we will give you some medicine in the form of an injection. So it's a mild blood thinner before the operation, and we will use some special stockings that will give you massages in your thighs and your legs during the operation to keep the blood circulating and prevent blood clots. And those continue while you're in the hospital. Also, staying active after the operation is very important to prevent blood clots. Some patients who need lymph node dissection may need additional blood thinners for some time, sometimes even up to a month after the surgery. and we will tell you if you're a candidate for that after the operation. Obviously, these blood thinners have a risk of bleeding, and we're very careful with making sure that there's no active bleeding when we finish the operation. But occasionally patients may need to have a blood transfusion, but the risk of that, in my experience, is 1% or less. So I do maybe 300 operations a year, and I would say maybe every other year a patient gets a blood transfusion, so it's not very common at all. During the operation, we may use clips that are either metal, these are titanium, so they don't cause problems in the airport, or they're plastic. And rarely they may migrate or erode into the bladder. I've seen it once or twice in my career. Patients who may have had a leak afterwards, and those were removed after time after surgery, but it can happen, and we're very careful with not placing clips near the bladder, but it is always a risk. Let me see if I'm missing something. I think we always put that there may be problems with the functioning of the robot. It's rare. The robot has multiple securities for that to prevent. Thankfully, I can do the operation robotically. I can always do it. I can also do it laparoscopically, and I can also do it open. So if it happens, I can finish it laparoscopically, and if it's not feasible to do it laparoscopically, then we would open with a very, very small incision. But again, that's very rare. I haven't had to do it over a decade. So basically, you after the surgery, you'll go up to your room. Like I said, you'll be eating and ambulating, walking around that same night. And I'll see you the next morning. I'm going to give you some instructions with some videos and also in person, just so you're well informed. And we'll also give you a hotline, a telephone number where you can always get a hold of us 24 hours a day if you have any questions. To avoid having to go into the hospital if you don't need to. After surgery, we will give you the pain medication called Neurontin for you to take, also Tylenol, and if you're not allergic to aspirin, some Advil to take. Usually narcotics are not necessary after the operation, so it's not a very painful operation. So I hope this was helpful. If you have any additional questions, we will answer them when you come for your visit, and hope to make this experience less stressful. One of the things I like about my job is that most patients do very well, and they're very happy and satisfied with their outcomes, and I hope you are too. So have a nice day. Take care.